Hello, I'm Howard Gurney from Macquarie University, and we'll be talking about an overview of prostate cancer. So at the end of this, hopefully you'll be able to describe the normal function of the prostate, know some basic statistics about prostate cancer incidence and mortality, describe the pattern of metastases, and know the principles of treatment. So we'll try and keep it simple. What is the prostate? And remember, it's prostate, not prostrate. Prostate is lying down flat. Prostate. So it's a small rubbery gland about the size of a golf ball, just in front of the rectum and just below the bladder and in front of the pubic symphysis. So that's the sagittal view. And if you look down here at the coronal view, so this is a CT scan, that's the hips, that's the pubic bone, that's the rectum, and the prostate just sits in front of the rectum and just below the bladder. So the prostate actually does something. It's important for reproduction. It supplies part of the seminal fluid, the semen, which mixes with the sperm, which is from the testes, and the seminal fluid helps the sperm travel and survive. So the prostate fluid is important for reproduction. So it does something. So prostate cancer, these are New South Wales statistics. So it's one of the most common cancers in New South Wales by incidence, and this is over a 5-year period. So almost 33,000 men have been diagnosed with prostate cancer over the 5 years. So even more than breast cancer and melanoma of the skin. So there's about 6,500 new prostate cancers every year in New South Wales, 20,000 every year in Australia. Down the bottom there, you can see it's mostly in older men, so it doesn't really occur in 30-year-olds or 40, or it starts to take off in the 50s. And most commonly, it's in the 60 to 75-year-olds. And strangely, there's a good reason for it. As you get older, like in the 80s and 90s, it's less commonly diagnosed, because if you're going to get a lot of cancers, usually you've got it by the time you hit 80. This is looking at the mortality, the death rate. No, it's not. This is looking at the extent of disease. So most of prostate cancer are localized to the prostate. So of those that are diagnosed, about 50% of them, or probably over 50%, are involving the prostate or regional lymph nodes. A small percentage have distant metastases. So most of them are localized cancers. And if you look down the bottom here, this is the prostate cancer diagnosis by region of birth. And generally speaking, westernized countries, USA, Australia, New Zealand, sub-Saharan, South Africa, England, they have a higher incidence. Asian sites have a lower incidence of prostate cancer. So here in Australia, we have one of the highest rates of prostate cancer per head of population. This is the mortality. So it's prostate cancer in New South Wales. It's a third most common cause of death. So after lung cancer, colorectal cancer, so prostate cancer is the third most common, fairly equal to breast cancer, and more common, say, than pancreatic cancer, lymphomas, melanoma, etc. The death rate per 100,000 population is reducing. So we always look at the death rate according to the population. So of course, as the population grows, you get more and more and more deaths from anything. So you have to adjust it by the population. So per head of population, the death rate is falling. And why? Probably for a better pickup rate. PSA blood tests came about in the 1990s, so we're picking up more prostate cancers. And of course, a lot of the treatments are better. The surgery, radiotherapy for localized disease, but of all the drugs that we trial in our trial clinic, a lot of those we started trial in the 1990s. And the fruits of our labour are coming to bear, where the prostate cancer death rate is reducing. So prostate cancer is not one disease. So if you actually look at, if you biopsy your prostate, there's different grades of cancers. So we call them grades, or sometimes we call them patterns. You can see this pattern here. That's a low-grade pattern. So that almost looks like a normal prostate. So that's a Gleason pattern, or grade 3. Gleason was a pathologist, and now that's called ISUP grade 1. So we have all these strange terms, a bit confusing sometimes, including for the patient. So these are low-grade cancers, and then we have high grade, so often pattern 4 or pattern 5 cancers. And the important thing about prostate cancer is never one grade. It's usually a mixture of different grades. So for instance, pattern or grade 3+4 is now called an ISUP grade 2. And if you have a grade 4+5, 4+5 or 5+4, that's an ISUP grade 5. So there's mixtures. So these low-grade cancers, if it's all low-grade, they're much more common. They're indolent and they rarely metastasize. Whereas these ones that have pattern 4 or 5, high-grade cancers, they're less common, they're aggressive cancers, and they commonly metastasize. So these ones we have to treat, because if we don't treat them, they spread and the patient can die. These ones, if we're sure that they're all grade 1 or low-grade cancer, then we don't have to treat them, we can watch them. The natural history is that even if you just leave these high-grade cancers, so if you look at this top graph here, these are people who were just observed with, say, Gleason, a moderate grade cancer. It took many years for them to develop metastases. So it takes about 8 years before the incidence of bone metastases start to see. And even then, not a lot of patients are developing metastases. So it takes years to develop metastases, generally speaking, for prostate cancer. Where does prostate cancer spread to? So simplistically, just 2 spots. Most of them to the bone. Most prostate cancer spread to the bone. Here we have a bone scan showing multiple bone metastases. And the second most common spot is to lymph nodes. So here's a CT scan looking front on. You have the aorta there, and these are lymph node metastases from prostate cancer. And sometimes you can have it spreading to lymph node only and not to bone, or bone only and not to lymph node. Or sometimes you can have it spreading to bone and lymph node. Cancers just can't spread anywhere. They can't spread to the brain, for instance. Prostate cancer doesn't spread to the brain, particularly early on in the diagnosis of cancer. Rare or uncommonly, you might find patients with liver or lung metastases. They're very unusual, and they have a very different course to the average prostate cancer. So mostly bone and lymph nodes. So on bone, if you look at x-rays, they have this peculiar appearance. We call them sclerotic bone metastases, where you get these as if somebody's coloured it in with chalk. So bone shouldn't look like that. And here again, there's sclerotic metastases in the bone or to the lymph nodes. And they could be anywhere. They could be in the pelvis, or they could be in the para-aortic area, or even up in the neck. The prognosis changed depending on metastasis, the sites of metastases. So, of course, if you're one of these uncommon ones, liver metastases, they have a worse prognosis, but they're not very common. So most are lymph node and bone, and patients who spread predominantly to lymph node only, they have a better prognosis compared to those with patients with bone metastases. And the rare patients with lung metastases are very similar to those with the bone metastases. But if you leave it long enough, the cancers will show up in other areas. And this is looking at autopsy series, where you can get these strange sites, pleura, the adrenal glands, peritoneum, meninges. We didn't see these, we didn't see any of these sites in the clinic up until recently, until we get these, we have better treatments, so patients live longer and longer and longer and longer. And now we're starting to see these unusual sites of metastases here in the dura. at the base of skull, or here an epidural metastasis causing spinal cord compression, or the liver. But these are uncommon in the clinic. So here's a question: prostate cancer, if it spreads, usually clinically found in bone only, B, bone or lymph node, C, epidural space and liver, D, almost anywhere. So what's the answer to that? So of course the answer is to bone and lymph nodes, the correct answer. So the principles of treatment. So if we're just talking about localized prostate cancer, remember low-grade cancers, they don't spread. So don't actually require treatment. So you can just watch them. You put them on surveillance programs. Why? Why do we watch them? Well, in case we made a mistake, remember it's done on biopsy of the prostate. You can't actually see the cancer in just like a normal CT scan. So these prostate biopsies are blind biopsies, template biopsies, where they might take 12, 20, or even 30 random biopsies throughout the prostate. And so you think it's low grade, but might not be. It might be a high grade cancer in there. So that's why the patients are put on a surveillance program where they're watched, and they might actually have other biopsies to make sure that they don't have a high grade cancer. So the high grade cancers, they're the ones that can spread. You can die from them. If it's localized, then we give them curative therapy. So that's usually by either radical prostatectomy or by radical radiotherapy to the prostate. And usually if you have radiotherapy, you have some antigen deprivation therapy thrown in with the radiotherapy. So if it's spread, if prostate cancer has spread, again, to bone or lymph nodes, it's not curable, but patients can live for many years, many years, as we'll find out in a second. So what are the goals of therapy? So of course, improvement in symptoms, you can get pain, weight loss, stability from the cancer. So trying to stop or delay that from happening is important. That's predominantly using drug therapies or radiotherapy to bone metastases, delaying complications such as bone pain, spinal cord compression, local progression of the prostate causing bleeding or ureteric obstruction. And of course, we also want to prolong survival. As long as we do those things as well, the icing on the cake is to make people live even longer. And predominantly that's done by drug therapies and to some extent to radiotherapy to the prostate, even in the case where it's metastatic disease. But usually if there's minimal, just a few little metastases, we still irradiate the prostate. That gives us survival advantage. So the mainstay of prostate cancer treatment, when it's metastasized, is androgen deprivation therapy. So going back to the prostate now, not even the prostate cancer, the normal prostate absolutely relies on testosterone. On the left here is a nice healthy looking prostate, or up the top, sorry, is a nice healthy looking prostate. Where if you take away the testosterone, the normal prostate tissue undergoes apoptosis, commits suicide. So the prostate itself shrinks, a lot of the cancer cells die. Same for the prostate cancer. Here's a healthy prostate cancer with testosterone, and here's a prostate cancer that's undergoing apoptosis if you take testosterone away. So prostate cancer doesn't like a no testosterone environment. Where is testosterone produced? 3 sites. Testes makes most of it. 90% of the testosterone comes from the testes. A little bit of it comes from other tissues such as the adrenal gland. And now we know that the prostate cancer itself can make its own testosterone. So those 3 sites make testosterone. How does testosterone work? So testosterone gets into the cell and it binds to the androgen receptor. This androgen receptor sits in the cytoplasm. So it binds to the androgen receptor, and the whole thing translocates to the nucleus and binds to these hormone response elements and switches on growth for normal cells, but also for prostate cancer. So looking at that again, the testosterone can get converted to a more active version, such as dihydrotestosterone. Either of them can combine to the androgen receptor. The whole thing translocates to the nucleus and switches on cell growth. So how do we take away testosterone? And we generally call that androgen deprivation therapy. So we can act on the testes, we can act on the adrenals and peripheral tissue and the sites that make prostate cancer, and we can also inhibit directly this androgen receptor complex. So the top, we can actually remove the testes surgically, both of them. That's called bilateral orchidectomy. Or we can use these agents that actually work on the pituitary gland that stops FSH release. And they're called LHRH agonists or antagonists. So they're usually injections. We can stop production in the periphery or in the tumor by these enzyme inhibitors, by this enzyme inhibiting this enzyme called CYP17. They're usually tablets. And there's a raft of androgen receptor inhibitors, and then we tend to call them anti-androgens. Again, they're tablets. So examples of the names for LHRH agonists, say goserelin, leuprorelin, triptorelin, degarelix is an antagonist. There's only one CYP17 enzyme inhibitor currently, abiraterone acetate, and there's a number of anti-androgens, and they all sound very similar. Bicalutamide, enzalutamide, darolutamide, apalutamide tablets. So again, how do they work? So you can do an orchidectomy. You can use these injections that block LH-FSH release. You can use CYP17 inhibitors, abiraterone, by stopping production of conversion of cholesterol into testosterone, or you can use these anti-androgens to block the androgen receptor. And I must say, the mainstay of these LHRH agonists, usually you have to be on those as a minimum. So there are other systemic therapies, of course. So there are these, well, as we know, there's these novel, we call them novel androgen axis inhibitors. They're really just second generation tablet therapies, enzalutamide, apalutamide, darolutamide, abiraterone acetate. So these have come into clinical practice due to trials that were done over the last 10 years, and now a lot of them are on the PBS. Good old-fashioned chemotherapy is very effective in prostate cancer, and the mainstay are two drugs, docetaxel and cabazitaxel. We have a number of different radioisotopes. Radium-223 is one which we trial here in Australia, but generally we don't use in general practice because it's not funded. But we also use other agents. So we use bone-targeted agents that can reduce bone complications. Drugs such as denosumab, it's a subcutaneous injection every month, or another drug called zoledronic acid, intravenous injection every month. And they both can act in the bone to reduce fractures, osteoporosis, need for radiotherapy to the bone, and can delay the time to spinal cord compression. So they don't act on the cancer, they act directly on the bone. Of course, we have new therapies, we have trial units. This is what we do. So some of the agents that we are studying in trials of these are PARP inhibitors. So 10% of patients have a mutation in these DNA repair genes. Commonly, they're breast cancer associated genes, BRCA or BRCA2, BRCA1 or other mutations. Importantly, they're not all, people think they're hereditary, only half of them are hereditary. And half of them actually just occur spontaneously in the tumour. So you pick these up these will only be in the tumour DNA, and these hereditary ones you'll pick up in the genomic, or in other words, normal DNA that you collect from the blood. So those PARP inhibitors, so these PARP inhibitors are called, these are tablets, olaparib, niraparib, rucaparib, talazoparib. So these are active in these patients with these DNA repair gene mutations. So other agents, so PSMA, there's a prostate-specific membrane antigen, PSMA. So PSMA is upregulated in more aggressive prostate cancer. PSMA is different to PSA. And you can actually get small molecules predominantly or antibodies and link them with the radioactive materials. So if you link it to gallium, for example, then you can use it as an imaging agent. So that's a gallium, that's a PSMA PET scan there on the right, which is showing all the areas in prostate cancer that are where PSMA is being upregulated. And you can do this imaging thing first, and then if it shows up, then you can link the small molecule with a therapeutic radioactive isotope such as lutetium or actinium, and that can be injected and go to these sites and irradiate those areas. So in a sense, a form of injectable radiotherapy. So typical treatment pathway: the patient is diagnosed with localized prostate cancer. They have localized therapy. Some of them may relapse. They go on an LHRH agonist, and then they receive, say, one of these tablet therapies. Some of these bone-targeted agents are introduced. Later, they'll have various chemotherapy agents, and then again, some experimental agents. So here's an example of one patient diagnosed with metastatic disease de novo, 2007, treated with an LHRH agonist called goserelin, started to grow back again. A tablet bicalutamide was added, a more potent anti-androgen was added, keeping his disease under control for many years. And then finally having docetaxel and then cabazitaxel, and this whole thing controlling his cancer for almost 10 years of his disease. So looking at that again, so that was what we used to do. What we're doing now, due to all of our trials, there's a lot of all this therapy is moving forward. So we tend to use a lot of this disease early in the course of disease, combinations of therapy right up front when the metastases are diagnosed. So we don't tend to get this relapsing and remitting disease. We just get a really big bang response that lasts for a long time, and then it starts to go back, and then we're looking at cabazitaxel chemotherapy and other experimental agents will move forward and further forward in the course of the disease. So in summary, prostate cancer is common. It's particularly in men aged 60 to 80. The natural history of prostate cancer is variable. In some patients, it never spreads. In the majority, it takes many years to spread. Some cancers have rapid growth. Initially, the prostate spreads to the bone and the lymph node or the lymph node. Testosterone is a major growth factor for prostate cancer. That's the target for treatment. Testosterone is predominantly produced in the testes, but it can be produced in other parts of the body and importantly in the cancer itself. How do we target that? Well, for localized disease, if it's low grade, doesn't require treatment. We just watch it. High grade, we try curative therapy with radical prostatectomy or radiotherapy. And then for advanced disease, we target the major source of production of testosterone by bilateral orchidectomy or blocking the LH-FSH released by the injections, the LHRH agonists, or by and on top of that, using enzyme blockers such as abiraterone or direct blockers of the androgen receptor, such as enzalutamide or darolutamide. But we have other agents, the bone-sparing agents, chemotherapy, radiotherapy, PARP inhibitors, radiotherapeutics, many other drugs that we're starting to trial in prostate cancer, and that's the cutting edge. That's where you'll be working, developing these new drugs that I haven't even listed here to bring them forward into the clinic, so patients can benefit from it. So that's the overview. And thanks very much for being involved. Thank you.